my screen has Carl Wurtz right now, so let's see. Now I got the gallery view. And so are you going to run the slide? Oh, what I was going to say, Caitlin, is if people could, if you would watch the chat for questions there, and I'll listen to questions here, and between the two of us, let's try to take the questions in the flow. So, you know, you could raise your hand if you have a chat question. I'm not going to try to watch the chat question. Please do that. And okay, so I'm ready. See Johnny's smiling face, which is great. There are two people with us from the Pennsylvania Rural Health Model. Aaron Erb from Armstrong County Memorial Hospital, or Armstrong County Medicine and Health Hospital, and Diana Carpenter from the Office of Rural, from the Department of Public Health in Harrisburg. And also, of course, we have Caitlin Grados from UPMC Black Lung, who is always, almost always with us, which is great. So I'm ready for the screen share if you want to put that up.
Dan, when you turn your head to your left, we lose your audio. Your microphone's very directional.
Okay, great. That's another problem we've seen a lot. So thanks, David. I'll try to talk straight on. Thank you. If you're losing me, just speak up or wave. All right, so this talk is about the GOLD guidelines. And since GOLD guidelines are updated every year, which is nice, this is the 2020 GOLD line that I mainly focused on. I have nothing to disclose, no financial disclosures. Next. This is the GOLD, by the way, is the Global Initiative for Chronic Obstructive Lung Disease. I find that hard to remember, but that's GOLD. Go ahead. The GOLD Board of Directors and the GOLD Science Committee, which oversee the GOLD guidelines, have a lot to disclose. In fact, when I took some time to really dig into this, I found that every single member of the Board of Directors and the Science Committee receives either grants or speaker fees from pharmaceutical companies. In fact, it looks as though being a speaker or a grantee of the pharmaceutical committees is a necessary requirement of being on the GOLD Board of Directors or the Science Committee. But that's not a reason to not use the guidelines. It's just important to have that in mind and those influences in mind as we go through them. It made me think about guidelines in general, and we use lots of guidelines, most of which are either from nonprofits like the American Diabetes Association or from NIH. And here are four that in my time as a family physician, primary care provider, I've used a lot. The annual diabetes, ADA diabetes care standards, the JNC, Joint National Commission guidelines for hypertension, which have been extremely important and are maintained from NIH, although not updated as much as they used to be. American Cardiology, AHA, so the American Heart Association. So here we see examples of nonprofits and governmental, high prestige, reliable governmental bodies putting out guidelines. But even here, many of the people on the committees have speaker fees or connections to pharmaceutical companies, which they disclose. Go ahead. And it made me think about guidelines in general. And there used to be a great national guideline clearinghouse run by the Agency for Healthcare Research and Quality. And when I went looking for it to find other COPD guidelines, I was sad to discover that because of federal funding cuts, it had been shut down in 2018. So that was some more bad news for me. Go ahead. And so mainly what I want to talk about today are the GOLD 2020 guidelines, but it's useful to think of them in parallel with other COPD guidelines. Allison Sela did a great talk earlier this year, or at least within the past 12 months, on the guidelines of the National Institutes for Clinical Excellence of the United Kingdom, NICE, the National Institutes of Clinical Excellence, is like their NIH, but really dedicated to providing evidence and policy recommendations for the National Health Service. And because of Grace Ann sending these really interesting just released pharmacologic guideline for the American Thoracic Society, it came at a perfect time for me. Thank you, Grace Ann. I wanted to include that one too. So here are the references for each of those. And for us who spend a lot of our time in COPD, I think these are important, and particularly on our topic today. Go ahead. And an interesting thing about these guidelines, and I'm contrasting it with how GOLD goes about its guideline, is that actually a number of the people who were participated in these in this guideline, the ATS guideline, are also on the GOLD Science Committee or Board of Directors. But the difference here is that the ATS maintains a little bit more objectivity and independence by having both co-chairs and 50% of the panel free from financial conflicts, and that the people on the panel with conflicts took part in the evidence discussions, but not participate in the formulation of recommendations. So it's two different examples of how to go about things. Go ahead. So a little history of the Global Initiative for Chronic Obstructive Lung Disease. It was established in 2004, so we're 16 years into GOLD guidelines. And certainly they've had tremendous influence, have been helpful for us, and in some ways have become, in the United States, the gold standard for COPD guidelines. In 2011, they introduced one of the things that are most used in the GOLD guidelines, which is their ABCD assessment. And it was a way of creating sort of a grading system for severity of COPD, and then tailoring both initial treatment and later treatment to how severe people's COPD was, both in terms of airflow obstruction severity and shut the door, and symptom and functional severity. And then in 2017, they made a really important addition. They think it's important, and I do too, which is they separated airflow severity, in other words, grade of airflow obstruction on spirometry, from clinical symptoms and functional severity, because they realized both in terms of prognosis and in prognosis for survival and prognosis for exacerbations and hospitalizations, that spirometry severity alone was not sufficiently predictive. And it's not for certain that the new ABCD classification, or new as of 2017, is totally predictive either, but they think, and many agree, and perhaps we can discuss that later, that it's definitely an improvement that makes sense. Go. So what I'd like to do is kind of imagine that you're in a new famous tourist destination city, and you're on one of those bus tours, and you kind of do a rapid ride through the city, see the highlights, and then you have time to go back and visit the places you want. I'm going to try to take you on a quick bus ride. Many of you, probably even all of you, have looked at the GOLD guidelines one time or another. If anybody's ever read the whole thing, any year, please mention that in the chat, and we will send you some kind of an award. I certainly had not ever read the whole guideline, and I still haven't. But in preparing this, I spent a whole lot more time with it than I ever have before, and that's a bonus for me. The current one is 125 pages, 6 chapters. If you frequently work with the GOLD guidelines, a frustrating thing, you can and should download the PDF and just keep it on your desktop. But the pagination is confusing, because the PDF is 141 pages, but the actual report is 125. And so you have to be specific when you're trying to mark things to page numbers, which you're using. As I said, it has 6 chapters. Okay, so the big zoomed out overview. Chapter 1 is just definition and overview of COPD. Chapter 2, how you go about diagnosing COPD and what is an appropriate initial assessment. Questions like, should everybody have a alpha-1 antitrypsin level? And I'm pretty sure the GOLD guidelines say yes. Questions about, does the spirometry have to be pre and post bronchodilator? GOLD says yes, NICE says no. Chapter 3 is evidence supporting preventive and maintenance therapy. And remember that unlike hypertension or even congestive heart failure, we don't have treatments. Not only does pulmonary rehabilitation not have a demonstrated survival value, but neither does any of this preventive and maintenance therapy that we do. There are some arguments that triple therapy, there are studies suggesting that triple therapy, brand name Trelegy, has some survival value. But for the most part, the treatments that we do are aimed at preserving function, preserving quality of life, reducing symptoms. And so all this evidence in chapter 3 is focused on those things. Chapter 4 is the one that I've used the most over the years and found myself frequently referring to and trying to get my team to use as a common language for us to talk about our patients with COPD, management of stable COPD, Chapter 5, management of exacerbations, and then Chapter 6 on COPD and comorbidities. Each of these chapters has key points at the beginning. And what I want to do is just go ahead and run through the key points for each one. And I don't think there's a ton of stuff in these that most of us don't already know about and haven't seen before. But as I went through them a little bit more closely, like driving the tour bus slowly instead of fast, there were some things that really stood out to me. So I'll let you know what those were for me. So this is chapter 1, definition and overview. 1, 2, 3, 4, 5 key points. Honestly, there was nothing here. Well, yeah, bullet point number 3. Main risk factor for COPD is tobacco smoking. So this reminds us that yes, tobacco smoking is the single most important thing. Hang on, I got to shut a door. I'll be right back. Yes, tobacco smoking is the single most important factor that causes COPD, which offers great hope for prevention and ties the question of COPD into the question of addiction. But also that between 20 and 30% of COPD is not caused by tobacco smoking, but by other environmental factors and some hereditary factors. And so that's an important thing to keep in mind. Interestingly, this key point doesn't mention occupation at all, but occupation is addressed in some other parts of the guideline, to be fair. So I think that's it. That was the main one for me, is to remember that just as everybody with cirrhosis is not an alcoholic, everybody with COPD is not a smoker or even necessarily a former smoker. Chapter 2. So chapter 2, diagnosis and initial assessment. I think the one that stood out for me here was spirometry, and that GOLD calls for pre and post bronchodilator spirometry. And if you read the guidelines, which many of you have, for Medicare qualifications for pulmonary rehabilitation, it requires moderate airflow obstruction on post bronchodilator spirometry. The GOLD guidelines, unlike the ATS spirometry guidelines, the GOLD guidelines has, as you guys know, has used a fixed FEV1 FVC ratio as the definition of airflow obstruction. That makes it easier to teach people about it, teach our providers, but it's not as correct as using lower limits of normal, which are a little bit variable around that 0.7. But at any rate, the GOLD calls for, defines, or requires for a diagnosis of COPD an FEV1 FVC ratio on post bronchodilator of less than 0.7. And then I think it's useful to remember 80, 50, 30. That GOLD categorizes spirometric or airflow severity of impairment using the 80, 50, 30 cutoffs, where less than 0.7, above than 80 is mild, and then 50 to 70 moderate, 30 to 50 severe, and less than 30 very severe. But used to be that NICE did not require spirometry for a diagnosis of COPD, but within recent years they have added that. So now everybody is aligned in terms of spirometry is required for the diagnosis of COPD. Next slide. So before we go to chapter 3, I just want to put in this COPD pyramid, because chapter 3 goes over the evidence for all the different treatments that we use. And I actually did read that chapter. And this pyramid, which some of you have seen before, is from the London School of Economics and something like the London COPD Work Group. It was done in around 2012, 2013, and they did an economic impact study of the different treatments we use. And this is expressing what is the cost to gain one additional quality of life year, which is an economic impact epidemiologic measure. What does it cost to gain one additional quality of life year with various treatments? And by far the most economic, if you have a National Health Service which has a budget which has to cover everybody, and so you make the economic decisions become pretty compelling. By far, flu vaccination gains the most additional quality of life years for the at-risk population, then stop smoking support, then pulmonary rehab, and only after pulmonary rehab do you start getting into inhaler therapy, and then finally telehealth is at the very top. And we're hoping that we had a good presentation 2 weeks ago, and I think you would consider that on telehealth, remote pulmonary rehab. And I hope that we can find a way to get that cost down so that there will be a stronger economic justification for that. So then with that prior point of pulmonary rehab rules way ahead of inhalers, and yet think about how many of our patients have inhalers and how many have pulmonary rehab, we can go to chapter 3. Now, chapter 3. So there's so many here that I didn't have room for the heading, but there are 13 bullet points here. And you can be scanning as I talk, and if anybody sees something they'd really like to shout out about, fine, but I'll tell you the ones when I kind of drove the bus slowly by these and really looked at them that stood out for me more than was already in my awareness. Number 5, countdown, 1, 2, 3, 4, 5. Inhaler technique needs to be assessed regularly. We'll come back to inhaler technique, but they're focusing it here, and it probably should be bolded in bigger font. So that number 5 about inhaler technique is, they emphasize it, and I don't think we can emphasize that enough. Number 8 is where they describe pulmonary rehab, improve symptoms, quality of life, physical and emotional participation. We know that that's what many of us do and how we first came together. And then number 11 here, which is the third one from the top, third one from the bottom, in patients with severe chronic hypercapnia, hospitalization, long-term non-invasive ventilation. And I know that's one that I really don't think about very much. Dr. Stansbury is an expert on that and gave us a great echo on that a few months ago. And probably, Caitlin, that's one we might ought to put on our annual core curriculum list, because we're probably underutilizing that. Anything anybody sees here that they would like to shout out about or is either new or important for you?
Hey, Dr. Doyle, I don't know if it was about this slide or I think it was about a previous slide, but there was a question. Is that okay?
Sure.
Okay. Does GOLD diagnosis require pre-bronchodilator spirometry or just the post-bronchodilator testing?
They recommend pre and post. Yeah, they recommend pre and post, and I think the rationale is that there's a number of reasons, but one of them is you're looking to see to what extent bronchospasm, and particularly reversible bronchospasm, is a component of the person's disease, because that enters into some of the decision trees that you'll see later about rationale for or against ICS, inhaled corticosteroids. So you really need both to know whether you have a reversible component of your disease. Okay, moving on to chapter 4. So chapter 4, these key points are kind of underwhelming to me, considering that this is the chapter I use and refer to the most. And maybe I shouldn't, but it's because of the figures in this table, which is the ABCD assessment model, and then initial therapy based on ABCD classification, and then a fairly complicated figure, but one that's worth looking at, and we will, having to do with how you make adjustments. In a way, JNC, Joint National Commission guidelines for hypertension, introduced the idea of stepped therapy. And, first you try this, and then if that doesn't work, you try that for control of blood pressure. And in some ways, Gold picked up on that and has modeled adjustments to spirometry therapy, and the ATS guideline that Grace Ann shared with us and that we'll look at does the same thing. So to me, there's nothing much new or different here. We have to dig into chapter 4 to appreciate it, but let's go on to chapter 5. Okay, a bunch of guidelines here, or a bunch of points here. So this is chapter 5 about management of exacerbations. And I think the main thing of all 11, bullet points that really I thought deserved emphasis here was important for me was bullet number 3. And that is, when you have somebody with an exacerbation, be sure to consider other possible causes than infection. And so we get kind of used to having our COPD patients call up and they say, hey doc, my breathing is worse, I'm coughing up more phlegm, can you call me in some Zithromax and prednisone? And we do it. And sometimes we do it over the phone, even before the pandemic. And now we're doing it a lot with the pandemic. Fortunately, sometimes we have can see the person because we're using video visits. But the important thing is to remember to consider the other possibilities, and what those possibilities, at least the main ones, are, would be, and this is not necessarily in order of likelihood, but certainly we have to consider exacerbation, sometimes initial presentation of chronic heart failure, or pulmonary edema. We have to think about the possibility of pneumothorax. We don't see it that much, but it happens. We have to consider pulmonary embolism. We also sometimes have to consider that people are getting into trouble with CO2 retention because they're turning up their oxygen too much, or maybe their oxygen is broken. We have to consider they're out of their medicines, and we have to consider they're not using their inhalers properly. But probably the big ones are pneumothorax, CHF, and pulmonary embolism. So I think that deserves, with exacerbations, that's one that we have to remind ourselves of. And other than that, I guess the third one from the bottom, methylxanthines are not recommended due to increased side effect profiles. I think theophylline and aminophylline are pretty much gone. I had a patient call me the other day who had been surfing the web looking for treatments, and he asked me about it. And I explained to him about the hazards, and he said, okay, gee, I guess I don't need that. And once again, they mentioned non-invasive ventilation. On to chapter 6. So chapter 6 is about COPD and comorbidities. Actually, there were 4 here that stood out for me that I felt like I wanted to remind myself of. Number 3, lung cancer is frequently seen in patients with COPD and is a main cause of death. So as you guys know, Medicare is now paying for low-dose CT scanning. Luann, I think, and Luann Jeffries at Cabin Creek Health Center, Brandy Bell at Lincoln Primary Care, have been participating in a national study by the American Cancer Society of low-dose CT scanning for early detection of lung cancer. And Brandy and Luann, I think that grant is still going, although it's in its last year. Is that right?
Yes, that's correct. I just talked with our contact, Shauna Schaefer, and I do have several more months to go on mine. Now, Brandy may have further. I know she started a little bit after ours, so hers may be more extended.
Yeah, Luann, I think I'm a little bit behind you, but still reporting quarterly to Shauna.
Sure.
So when those grants end, LDCT doesn't end. It's really helpful to have somebody like Brandy and Luann who are tracking that for us and reminding us of it, and helping the patients get through the certification loops and have the forms filled out correctly and following up. But this is, so far, a CMS improved benefit and screening program. So that stood out for me. Two more down, osteoporosis, depression, and anxiety are frequent, important comorbidities, often underdiagnosed, associated with poor health status and prognosis. And you can understand why poor health status and prognosis would arise from those, because with osteoporosis, people fall and get fractures, the worst of which is are the hip fractures, but the the vertebral compression fractures are bad, the forearm fractures are bad, and you can see how that could really take away a person's ability to keep up their physical activity and exercise. And with the depression and anxiety, as you know, that can wreak havoc with all kinds of things: not taking your medicine, not getting exercise, feeling hopeless and helpless. And remember that the treatment of osteoporosis and the mental health conditions like COPD is not immediately or only prescribe a drug. There are non-pharmacologic treatments or less risky pharmacologic treatments for both of these: vitamin D, calcium, physical activity for osteoporosis, CBT, chronic cognitive and behavioral therapy for depression and anxiety, and then as adjuncts, the biphosphonates for osteoporosis and the SSRIs, not benzos, for depression and anxiety. And then the GERD, it's important, says it can increase risk of exacerbations. And then finally, the last one, part of a multi-morbidity care plan, pay attention to keeping regimens simple and minimizing polypharmacy. And anybody who works with our Medicare geriatric patients and looked at their med lists knows that they're loaded with Beers List meds, and there's a lot of work to do there. So I kind of have considered this COPD and comorbidities chapter kind of a throwaway chapter in the past, and I know all that, and there's nothing there for me. But when I just took time to read even these 7 bullet points, there was a lot here that I felt I needed to be reminded of. So that's the quick drive through the City of the Gold guidelines. And so now what I'd like to do is go back, and I don't see the time on my desktop. How are we doing, Caitlin?
We're at 8:41.
Whoa. Okay. So next slide. So I thought we should do a case. And this is a case that I presented at an ECHO session in 2017, where we were talking about, that was the one, for those of you who were there then, we had the chant, SABA, SAMA, LAMA, LABA, ICS. But basically all these almost now scores of inhalers really boil down to 5 classes of drug. Short-acting beta-adrenergic, short-acting muscarinic agonists, long-acting beta-adrenergic, long-acting muscarinic agonists, and inhaled corticosteroids. So here's a patient in 2017, 57-year-old woman, severe COPD. You can see her med list: Symbicort, Ventolin, Albuterol, Daliresp, Montelukast, Flonase, Oxygen, hydrocodone 10, I'm not sure how much, let's just pretend it was BID, and diazepam 10 PID. And I put her spirometry up there, and and this is post bronchodilator spirometry. Her ratio was 66%, so definitely less than 0.7 or less than 70%. Her FEV1 39%, which so that's that. Her CAT, which you respiratory therapists know, the COPD assessment test was 25, and anything above 10 is significant in terms of ABCD assessment. And she had 3 exacerbations in the past year and 1 hospitalization. Next slide. So keeping that in mind, now we get back to chapter 4, management of stable COPD. And these two, and actually the one on the left there, the refined ABCD assessment tool, is from chapter 2, diagnosis and initial assessment. And it becomes relevant for picking initial treatment. Because of our time, I mean, we could spend a half hour just talking about this, but we don't have the time. Just keep in mind that with this assessment, the ABCD assessment tool on the left, as you will recall, was modified in 2017. In effect, what you're doing is each patient, each COPD patient, when you diagnose COPD, you're giving them a grade, and the grade gold 1, gold 2, gold 3, gold 4 is the same as us saying they have mild, moderate, severe, or very severe airflow obstruction.
I'm sorry, your audio is cutting out again.
Yeah, Dan, just talk more quietly to the computer. I think we'll be okay. Just talk more quietly. Don't talk louder.
Okay. How is this?
Much, much better.
Thank you, Carl. Good coaching. So each person you give a grade, and then you put them in a group. And the group is A, B, C, or D. This is worth, I encourage all the teams, and we try on our teams to use this on a regular basis. What's her grade? What's her group? Because that gives us, if we rely on the GOLD guidelines, and mostly we do, a basis for critiquing what is her current inhaler regimen. And as you can see over here, if they're in group A, and this is for initial pharmacologic treatment. Most of the time in pulmonary rehab, we're way down the road, and what we're doing is more adjusting their treatment. And usually we're not in control. They got a primary care provider, they got a pulmonologist, but it makes sense for us to ask ourselves, is this person on an appropriate regimen based on the GOLD guidelines? And so if you go to the next slide, what you have now is you have that initial pharmacologic treatment on the left, and you have this figure 4.3, which is also in chapter 4, management of stable COPD, as a GOLD flow sheet, both for increasing or stepping up inhaler treatment and stepping it down, mainly stepping it down in relation to taking away inhaled corticosteroids when they are no longer indicated or not providing benefit. If we have time, I'll show you the slide that brings up the question of ICS and pneumonia. But basically, what both the GOLD guidelines and the ATS guideline came down on is that, yes, there is an association between ICS and pneumonia in people with severe COPD, but ICS reduces overall exacerbations much more than the increase in pneumonia. So it's a little bit complicated deciding who needs to be on ICS and who doesn't. There's no question in my mind, we have many, many millions of people on ICS who are deriving no benefit, but this very busy slide or very busy flow sheet is one, if you haven't studied it, it's worth walking through it. If you just take your time, read the notes, follow the rationale, I think it's very useful, and there's not time to say more than that, but it's in chapter 4. Next slide. Again, emphasizing inhaler education, inhaler misuse from the GOLD guideline, chapter 3, page 54. They're just stressing the importance of inhaler education, and our respiratory therapists do that in pulmonary rehab. how much, I don't think our nurses or providers do it almost ever at regular follow-up visits, and we should. And that should include actually having the person bring their inhaler, take it out, put it together, and show us how they use it. But because what's the point of stepping up to triple therapy if you're on dual therapy and the person isn't doing it right? Over on the right, GOLD guideline, a rigorous prospective observational study of COPD patients discharged from the hospital confirmed appropriate adherence to the use of the powdered inhaler, one type of inhaler, in only 23% of patients. So I don't think we're even close on making sure people are using their inhalers correctly before we're stepping up. Next slide. Having said that, I'm coming back. Okay, so Johnny has a comment here. Making sure they have spacers and are trained on them should be a really big goal there. Agreed. And that is not a super expensive thing. So blah, 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 enough said. So I took the case that we had looked at before, and you saw what that person's, so this is, again, giving you another look at the same slide, what their meds are in 2017. And based on those flow sheets that I just showed you, how would we change, if we had the same patient now, how would her med list and her treatment look different? And the next slide shows what I think that is, what the difference would be. So now, number one, she would have pulmonary rehab. Number two, she would be definitely on triple therapy. She would still have her 2 short-acting inhalers for acute rescue therapy. She would still be on her roflumilast Daliresp. She would still be on her oxygen. She might be on non-invasive ventilation. She would probably be on an SSRI for her depression. She'd be on metformin for her type 2 diabetes. And at the bottom, I put the things in smaller font that I think that we would have taken away by then. Symbicort would have been replaced by triple therapy. We would have tapered her off the benzo, which is probably dangerous for her, being a strong respiratory depressant. But we would have had to do that very, very slowly. And with replacement with the SSRI. Probably the montelukast and Flonase weren't doing anything, so I would simplify those away. And it might be to your surprise that I didn't take the hydrocodone away, because in a second, I'm going to show you the 6 recommendations that came with the ATS guideline, recent guideline. And interestingly, in people with severe COPD, with refractory dyspnea, they actually make a conditional recommendation for use of opiates for that. So that's how I think her treatment would change in light of the guidelines as they stand now. Anybody want to comment on anything here in terms of this care plan for this patient?
Hey, Dr. Doyle, I just wanted to let you know we do have a question. I can hold it for about 5 minutes if you'd like.
No, go ahead.
Okay. Sorry. So for those just starting out pulmonary rehab, people go through a lot of PFTs to see what percentage of qualifications will work in the hospital. So based on CMS guidelines, FEV1 FVC ratio of greater than 70% and or DLCO of greater than 60% would qualify COPD patients for pulmonary rehab, correct?
I think it's the other way, less than.
Less than, yes. Thank you.
Yes, I believe that's correct. Does anybody know different? Well, actually, yeah, it would have to be, for CMS, pulmonary rehab qualification, Medicare, it's the ratio, FEV1 FVC ratio less than 0.7 and the FEV1% less than 80. So it has to be both those things. That's the definition by GOLD guidelines of moderate COPD or worse. And it's interesting that the GOLD guidelines use, that the CMS guideline and the Federal Register use the GOLD cutoff, the GOLD definition, rather than the ATS lower limit of normal definition. But does that answer the question?
I believe so. Thank you.
Comment on this treatment plan for this patient. Anything missing? If not, go ahead. So a few final points. So trying to compare and contrast GOLD, NICE, and ATS. One thing is, what's initial bronchodilator treatment for moderate COPD? GOLD says ProAir, Ventolin inhaler, and if that isn't taking care of them, then dual therapy. It's that. I'm sorry. Yeah, that's what GOLD does. With that little table I showed you, initial treatment. I think it's figure 4.2 in chapter 4, where you're using the ABCD assessment categories to then guide step therapy. They start with a short-acting ProAir, Ventolin, Provenal. Then the next step for the people who are A, then the next step for people who are B, they would do a LABA or a LAMA. Then the next step, the people in the C category, they would add ICS, or they would, if you're on LABA, they'd add LAMA. And then finally in the group D, they get up to either triple therapy or LABA-LAMA therapy. NICE basically is the same as GOLD, and ATS starts right off with LAMA-LABA. And that's partly because it's more recent, and they move very quickly to triple therapy. Next slide. Just to remind you, what are the LAMA-LABA inhalers? Because I have a hard time myself remembering them. On the left, this is taken from chapter 3 of the GOLD guidelines. There's a table here of what are the different LABA-LAMA using their chemical generic names. And then over to the right shows you what are the brands and the company with each one of those. And probably what I see the most by our pulmonologists around here is the Anoro Ellipta and the Stialto Respimat. And there is a rationale for that. If you look to the left there, you can see that they're prescribed every 24 hours. So that long-acting efficacy makes sense to me as a reason why I would favor those. If you dig more in, no, that's ITS. Okay, next slide. And then what about stepping up to triple therapy? As Trelegy of Oradonecene, a product of GSK, Glaxo, Smith, Klein, there's a lot of pressure for getting everybody on Trelegy. You see the pulmonologists doing it. And you wonder, have all of those people really had their inhalation technique checked on their LAMA-LABA? But so there's a big assumption here about this step up, which is they're doing everything else right. They've done their smoking cessation. They have had their pulmonary rehab, and that isn't what happens in the real world. But we're better than the real world, and we should be making it happen. So for GOLD, stepping up to triple therapy is based on dyspnea or exacerbation, and that figure about that busy figure I showed you, that's where you could see how that works. NICE, 1 severe or 2 moderate exacerbations in the past year on LAMA-LABA, doing everything right would be a reason to go to triple therapy. So the National Health Service hasn't said, no, we're not paying for that expensive inhaler. They're paying for it, but with this indication. And ATS, essentially the same. So really, there isn't a big difference among the 3 in terms of recommending this step. Next slide. Now, I couldn't, it was really hard to copy stuff, so I had to use screenshots. But there are 6 recommendations from this ATS guideline just released on about May 1st. Just wanted you to see what they are. So if you look in results, you have to sort of zero in on the fine print here. Number 1, basically start with LAMA-LABA. And they don't even say for mild or moderate disease. They just say start with LAMA-LABA. If people with COPD have dyspnea or exercise intolerance, which almost all the people with moderate airflow obstruction do. Number 2, they say go to triple therapy for people who have experienced 1 or more exacerbations in the past year, which is almost everybody. Number 3, everybody with moderate or more, or maybe not everybody, but a significant percent, and most of our people in the severe category, or the A, B, C, D, C, and D categories. Number 3, take away inhaled corticosteroids for people on triple therapy. In other words, okay, you got them on Trelegy for a year, but if they've had no exacerbations, spare them the pneumonia risk that comes with the ICS. So that's an important one. Number 4, they made no recommendation for or against inhaled corticosteroids based on blood eosinophil levels. And unless exacerbations is the indication, but they're not using blood eosinophils alone as a reason for inhaled corticosteroids. Number 5, don't use oral prednisone for maintenance therapy. We already knew that. And number 6, here's where they talk about a conditional recommendation for opioid-based therapy in patients with COPD with refractory dyspnea. So those are the 6 recommendations there. It's worth taking a look at that. It's a really interesting document, and one of the things interesting about it is that for each of these recommendations, there's actually a description of how the discussion within the committee went. Next slide. Here's the ICS and pneumonia business, and doing this was helpful for me to look at that more. It's kind of complicated. On the left-hand side from the evidence chapter, they talk about and they cite some of the data about the risk of pneumonia. They do say that risk mainly the risk of pneumonia as an adverse effect of inhaled corticosteroids. They say that mainly has to do with people of more severe disease. It says that this is not, last sentence on that left-hand side, in studies of patients with moderate COPD, ICS by itself did not increase the risk of pneumonia. They say it a couple studies. But then over on the right-hand side, in the ATS document, they point out that patients treated with triple therapy had 15 more pneumonias per 1,000 patients, but they had 230 less exacerbations. And that's why the panel concluded that there it outweighs the risks. But if they've had no exacerbations in the past year, remember that the ATS guideline recommends withdrawing. So I would really challenge us to get some of these people who are on Advair for life off it and switch them over to a LAMA-LABA. Next slide. So these are my takeaway points. Number 1, primary and secondary prevention are the best. We get so much into which inhaler to use that we forget that COPD is a preventable disease. Number 2, pervasive corporate influence on the writing and dissemination of the GOLD guidelines. It's there, be aware of it, but it's true in almost all the guidelines, from the ADA, from the NIH, probably from NICE. It's just that it needs to be disclosed and we need to be aware of it. The GOLD guidelines are pretty silent on affordability and equity and access. In other words, they don't talk much about how expensive these things are. They're all over $300 a piece. And Medicare Part D, for many people, doesn't cover. And yeah, there's patient assistance programs, but that's not enough, in my opinion. Despite these limitations, GOLD guidelines are important and useful, but we should keep watching the NICE guidelines. And I hope Allison, who shared her talk with me when I was getting ready to do this one, will keep presenting those each year. Use those GOLD figures, the ABCD, the initial treatment, and the adjustment flow sheet. Print those out, hang them up on your bulletin boards, and pay attention to them. If there's no asthma and no exacerbations in the past year, we can get them off the ICS and take away the pneumonia exposure. When should you start LAMA-LABA and when step up to triple? There's debate about that. When you really look at the fine print, there's debate about that, and it's really in the clinical decision-making step by step rather than on the paper of a guideline. Remember pulmonary rehab, remember inhaler education. We didn't talk much about oxygen, but it's important. GOLD and NICE differ a fair amount on oxygen, and remember non-invasive ventilation. And if you want to learn more about the gold guidelines, offer to do an echo presentation. It's a great way to learn more. You know, see one, do one, teach one. When you teach one, that's when you learn the most. And that is the end. I'm sorry I took a whole hour.
That's okay. We have, you know, we're at time, but if anybody has any questions, you're also welcome to email me. I know, you know, if you have something going on.
Dan, with a quick question here. So how, right now we're not supposed to do spirometry, which is the key determiner of how to deal with people and adjust their treatment. How are you dealing with that in our pandemic, post-pandemic world, which I fear we may be in for the next, who knows, long time?
You know, I had hoped to get through my slides in 35 minutes. How naive of me. And I really wanted to discuss that question. And I would really appreciate if we could do an echo in the near future on that question. And Carl, I might even volunteer you. Lisa Emery and I talked about that together. That's our respiratory therapist at New River. And we actually brainstormed a list of things that we're planning to do differently. But getting back to spirometry and what's it going to look like is really, really important. I don't have the answer, but we need an answer, and we need it soon. And so I would love it if we could schedule an echo session on that soon.
Certainly. So Dr. Warrens, if you're happy to do that, I can plop you on the schedule. I'm actually getting ready to send out the schedule for the second half of the year. So I'm just going to have to make an addendum. No worries.
Yeah, and I don't know if this is, to me, that's a very timely question for, I think, almost everybody that's on this call. And I was trying to figure out if ATS had addressed it. And as far as I can tell, other than saying stop, they haven't said anything else. And I think that may be something we want to look at. And I would say sooner rather than later. Like the faster we can, I think we're not going to come up with a solution necessarily, but I think talking about what the options might be would be useful to this group.
Sure. Are you okay to lead that?
I'm okay to lead that. And I said sooner rather than later. I mean, not next week, but in June or early July.
Yeah, let me look at the schedule. Definitely by July at the latest, but maybe I can squeeze you into June as well. Grace Ann had a comment. Let's see. Her contacts say that spirometry as we know it will not be available for a couple of years. Too dangerous for the coach. Yeah.
I agree with that. The hazard is to the worker, not to the patient. We just have to figure out there has to be a way to do it. And as I said, there's a lot of people trying to figure out how to deal with exhaled breath and filtering. Right now, we're redoing all the CPAP and BiPAP machines because they're the right treatment for all these folks that have COVID in the high COVID areas, and they had to put people on mechanical ventilation because you can't use the CPAPs all vent to the room, and the problem is spirometry vents to the room. We have to figure out how to deal with that. I'm not saying I know this solution, but I know what the problem is.
No, definitely, and we can make that a discussion. I
think that will end up being a heavily discussed topic, and I said I was hoping ATS would say something by now, or at least hint that they're thinking about saying something, but I've not been able to find anything. So we may be leading the world in how to resume spirometry. And I think that's not a bad thing.
Thank you. Yeah. Well, guys, we're almost 10 past, so I'm going to call it. Hopkins is working on it. And then Johnny says they are already scheduling us for them next month. So definitely this is going to be a heavily discussed topic, and I will get it on there as soon as I can. I think Dr. Stansbury is scheduled for the next echo session. I believe it's on asthma. I'm sorry. You guys will see it in the reminder. But if you guys have any further questions or anything else you'd like to talk about, just shoot me an email and we will get it on there as fast as we can. But everybody have a wonderful day and week and stay safe.
Thanks, everybody.
Thank you, Dan. Thanks a lot.
Mm.
Bye-bye.
Bye.
Bye.